Converting a peripheral catheter to an intermittent infusion device. Intermittent infusion devices can be left in place the remainder of a hospital stay following discontinuance of a continuous IV fluid infusion. Intermittent infusion devices are used when the need for an IV access is potentially required. For example, some facilities will require IV access when a patient is on cardiac telemetry as a standard of practice. Many facilities recommend connecting a lock with or without tubing directly to the IV cannula when you first obtain IV access. It saves problems when you are discontinuing continuous IV fluids or when you are wanting to do anything with the IV itself because you already have the lock attached. Excuse me. In this case, conversion will involve just disconnecting the mainline tubing and then flushing the site via the lock. You need to follow facility policy as to the solution and the amount of solution that you flush the intermittent site with. Most facilities these days will use a 3 to 5 ml of normal saline. These are some alternate terms for peripheral intermittent infusion devices, and two of the most common ones are going to be your heparin lock or your saline lock. Facility-specific policies can be more restrictive than state policies, but they cannot be less restrictive than KSBN standards. Remember that tubing should be labeled to indicate when they should be changed. When an intermittent infusion is repeatedly disconnected and reconnected for the infusion, there's going to be an increased risk of contamination at the hub, the needleless connector, and male lure end of the administration set, which will raise risk for potential bloodborne pathogens. If a secondary tubing remains connected after verifying fluid compatibilities, you can actually back prime into the secondary tubing to maintain that closed system. You can do that with some IV pumps, or you can do it through gravity flow. The usual standard for changing infusion tubing for a continuous basic IV infusion tubing, it's at least every 96 hours. With an intermittent infusion where it is repeatedly disconnected, it will be at least every 24 hours. For your secondary administration sets for a continuous infusion, if it's not disconnected from the primary tubing, then it can be changed every 96 hours. If it is an intermittent connection, in other words, it's disconnected from the primary tubing after it has infused, then it should be changed about every 24 hours. TPN, or total parenteral nutrition tubing, with or without lipids that include the filter, should be changed every 24 hours, and lipid tubing should be changed every 24 hours. Blood tubing, including a filter, should be changed at least every 4 hours, or if you infuse different blood products. It's recommended prior to, after, and/or in between infusions to flush intermittent devices with normal saline, and then you will lock it after the final infusion. You again flush it per facility policy, and you use normal saline or a heparin lock solution the majority of the time. Follow your facility-specific policies for flushing. Now, a lot of facilities do have the pre-filled 5 to 12 cc preservative-free normal saline syringes for this particular purpose. The volume amount is usually going to be more than the amount of the catheter that has been left for IV access. If a facility does use a bacteriostatic normal saline, it contains benzyl alcohol as a preservative. So the maximum volume that can be tolerated by adult patients should not exceed 30 mLs per 24 hours. Make sure that you document each flush on the medication administration record. With dressing changes, those should be completed per facility policy. They should also be completed when the dressing gets soiled or the dressing integrity is compromised, and if you see signs of infection at the insertion site. A sterile dressing is applied to all vascular access devices, whether it's peripheral or a central site. When you are getting ready to make the dressing change, you want to tear your tape prior to actually removing the dressing, or have someone tear it for you as you need it, because it's very difficult to, number one, tear tape when you have gloves on, and number two, to tear while you're trying to hold the cannula in place. So you remove the old dressing and the tape while maintaining digital pressure to the cannula to prevent dislodgement. Cleanse the site with the recommended cleanser and allow it to dry. Then re-secure a device and place a new sterile dressing. Make sure that you label the dressing, indicating when the dressing change was done, and document the procedure in the medical record. Patients that have central venous access devices at home need to be educated on the signs of infection and dislodgement, and that they need to report problems immediately. Antiseptic solution that's used in the cleansing of these sites is usually chlorhexidine, but chlorhexidine is not recommended in patients that are under 2 months of age. You can also use iodine and sterile water, and you can also use normal saline to wipe iodine away from the skin. There's many prepackaged dressing kits available. This dressing change is a sterile technique, most definitely. The biggest difference in a peripheral and a central line dressing change is that with a central line, you're going to wear a simple face mask. The mask goes on before you remove the dressing, and it does not come off until you have the new dressing placed. A dressing change should be done at least every 5 to 7 days. If you use gauze under the bio-occlusive dressing and it covers the insertion site, then you consider that to be a gauze dressing, and that should be changed every 2 days. But if the gauze is just used to support wingtips on a Uber needle, for example, that's used to access a portacath, and it does not obscure the site, then it is not considered to be a gauze dressing. The dressing should be labeled with the date, time, and initials of the nurse that's performing the dressing changes, and document the procedure in the patient's medical record, of course. Site rotation in pediatric patients should be avoided. If you cannot replace a site, or a medication administration is delayed because you have lost an IV site or have not obtained one yet, then you need to make sure that the physician is notified. If bloodstream infections are suspected, then you need to consider culturing the catheter tip. IVs that have been placed in emergency situations should be replaced due to the increased risk of the introduction of pathogens during insertion. Your standard over-the-needle catheter or your winged set infusion is usually changed every 48 to 72 hours if possible. If the site rotation is not possible, then you need to obtain a physician's order to extend the dwell time of the catheter. There is an exception when you have limited peripheral IV accessibility. Then it's essential to document the reason for not doing site rotation and document the appearance of the existing site and then closely monitor the existing site for developing complications. With specialty catheters, your midline catheters, the optimal dwell time is not known, but it is recommended to consider limiting the dwell time to 2 to 4 weeks. With your PICC line, you again, the optimal dwell time is unknown, and the recommended dwell time can be up to 1 year. And special factors necessitating changes in the IV system. In addition to what's listed here, you need to be aware of the fluid container. Those containers that contain your dextrose or any type of feeding are really subject to bacteria growing within that type of medium. So those containers should be changed excuse me, about every 24 hours. The administration sets for those fluids should also be considered, especially with TPN, to be changed every 24 hours also. And again, if you have a postcode or an emergency placement, you need to change those as soon as possible. But especially if the IV site was done at a non-traditional type setting. For example, it was a paramedic start at the site of an auto accident, then you really need to make sure that you start a new site within 24 hours, replacing all of the original IV system.